Dr. Halleck, it looks like this is a beautiful video of our previous
yeah, I
right?
think
For
he's
those
running
watching,
that 2020 video from February.
That's right, before the pandemic hit, and what
Yes, that's right.
what a pleasure it was to have so many attendees there nationwide, worldwide actually, coming together to talk about cardiovascular disease intervention and prevention. This is our first attempt at this Zoom webinar, so I think some sound is missing on this video, but we do have some lovely music that goes along with this video, but hope you all can enjoy and feel the passion and the energy in that hall, and how we really were able to present so many great things.
Okay, Doc. So this is a heart matter that for the public educational program. It was a great time. We have a great time that time, huh? Hopefully next year it will be good again.
We look forward to being together, all together again, but this is a great way in the interim.
Okay, great. You can, I will get my slide back again. Okay, I guess we go ahead and start. Everybody's ready to go?
Yes.
Okay. Well, Bismillah ar-Rahman ar-Rahim, in the name of God, the most merciful, most gracious. On behalf of my co-chairman, Dr. Krager, and all the dear speakers and the organizer and myself, it's really my great pleasure and honor to welcome all of you to this special edition of 40S and COVID. All of us in the last few months, we witnessed this catastrophic problem we have, which affect our health in general, and our heart in particular. And we felt it's with so many informations and report and concern and questions, we felt it's really, we need to do a special edition about COVID, waiting for the schedule 40S of mid-February will be too long. So we have a little bit of discussion, and we thought it's a good idea to do this special session or special edition of 40S and COVID. The story with COVID, as you know, it is a very little creature, which is you cannot see. You cannot even see with microscope. And you have to go to electronic microscope to be able to see it. This little creature actually put the whole world on hold. It was they estimated that only 1 gram of this virus did the whole thing and did the whole effect on the whole world. For the first time ever, the whole commercial airline were grounded. Most of the car around the world will put in the garage. The busiest street in the world were empty. They estimated more than 3 billion people around the world. They locked down at their home, no visitation. It was really very serious catastrophe affecting the whole world from far east to far west. So far, there's about, up to last night, there was 20.6 million confirmed case of COVID worldwide, 12.8 million recovered, and 749,000 people died from COVID. So it is very, a huge pandemic with significant impact on human life, in addition to all the life, actually. The economy, individual economy, and financial economy to the countries and individual. Now, to put that, need to just remember that cardiovascular death in the same corona pandemic period was about 9 million deaths. So remember, in the COVID so far, we have less than 1 million. We have about 800,000. Now we have 9 million deaths from cardiovascular disease. So if you want to make it during corona pandemic, every 2 minutes, every minute, 2 people die from COVID. In the same minute, 26 people die from cardiovascular disease. Just to keep that in mind. I know everybody in the world were so kind of alerted about the COVID things, and everybody take all the precaution needed to avoid COVID. But I think we have still a huge room for improvement to take care of and prevent the cardiovascular disease. It's still about 10 to 15 times death from cardiovascular disease more than COVID. In this meeting, yesterday we maxed up on the registration, and now we have that YouTube link for people who want to add on, and I think we have more than 600 people already there. All the talks will be recorded, and it will be put on the website of 4TS, www.4tsconference.com. The CME accreditation was applied for, but we didn't confirm yet, but will be certificate of attendance. Enjoy the meeting, and we'll hopefully you have a great, informative, interesting meeting tonight. Thank you very much for being here. I think Dr. Annie probably going to introduce the next speaker.
All right. The next speaker is going to be one of the most favorite people in the world for me, Dr. Zvonimir Krejcir. And let's see here. All right, good. So Dr. Krejcir, he hails, of course, from Croatia, but he has been in Houston, Texas for so many years. And I don't have to look at his CV because I know that he's an amazing man, researcher, teacher, very near and dear to my heart. And he started this International Society of Endovascular Specialists. And world over, he's taught so many of you who are on the call, and so many who want to be taught by him from the Texas Heart Institute. So I heartily welcome Dr. Krejcir to the meeting, and he's going to speak about coagulation abnormalities in COVID patients, D-dimer, and troponin elevation, what to do about it. Dr. Krejcir, please take the wheel.
Thank you, Annie, for this great introduction. It is my, can you see my screen?
Yes.
It is my special pleasure to partner again with 4T's and program director, Dr. Omar Halak, who's a great friend of mine, and extremely visionary individual as far as what needs to be done in United Arab Emirates for education. And we have been very successful in doing this through 4T's program. So as Dr. Halleck mentioned, this is very appropriate to discuss at the present time COVID-19 and impact of COVID-19 on cardiovascular diseases. The topic of my presentation today is coagulation abnormalities, D-dimer, and troponin elevations in COVID-19, what to do about it. Now, to set the stage for all the things that we will discuss today, I wanted to start with a publication that was published in JAMA Cardiology on March 27, 2020, by one of our former graduates from Texas Heart Institute Fellowship Program, Mohammed Majid, who is here in Houston. And he basically, at that point of time, in very early stages of COVID, reviewed all the available literature and summarized all the effects of the COVID-19 on the cardiovascular system. And as we can see on this diagram, schematic representation, we can see that there is direct vascular infection. There's systemic pro-inflammatory stimulation, particularly in cytokine storm, hypercoagulability, sympathetic stimulation, myocarditis, direct myocardial infection. All of those can lead to myocardial infarction risk, heart failure risk, and significant arrhythmias. Now, to set the stage for the next presentation, let's start with SARS-CoV-2 and how does it work and how does it affect our body and cause problems such as thrombosis. We know that SARS-CoV-2 has a special affinity to ACE2 receptors, and this is the mechanism how it enters into the cell. Those receptors are abundantly present in the respiratory tract, vessels throughout our body, arteries and veins and microvasculature, extensively present also in myocardium and adipose tissues and many, many organs. And all of this leads to a very aggressive inflammatory reaction that increases the inflammatory markers such as interleukins 1 and 6, tissue necrotic factor, and then this stimulates plasminogen activator inhibitor 1, and all of those have effect on stimulating the cytokine storm when actually the inflammatory response is excessive. And that obviously leads to many, many problems, but one of them is endothelial dysfunction that stimulates coagulation cascade, platelet activation, and fibrin deposit in the vessels that leads to thrombosis. Now, as far as arterial and venous thrombosis is concerned, we can see here on this particular presentation that cumulative incidence of venous and arterial thrombosis events in COVID-19 can be above 30% in our patients. And that could manifest itself as pulmonary emboli, either macro or microemboli, clotting over the central venous line and CVV-HD lines, myocardial infarction, stroke, DVT, and VTE can occur in spite of prophylaxis that has been clearly shown. And then the worst scenario is disseminated intravascular coagulopathy. Now, we can see for one of the publications the effect of heparin on the incidence of mortality, and obviously related to thrombosis, whether you are receiving heparin or not receiving heparin. And we can see that the heparin non-users have a significantly higher mortality than heparin users, but even with heparin treatment, the mortality is prohibitively high. So let's talk a little bit about cardiac troponin in COVID-19. We know that cardiac troponin increase is common in COVID-19 patients. It's more common in patients with chronic cardiovascular disease, and also indicates severe COVID inflammatory response, and it definitely has adverse prognosis. Elevated troponin can be classified as acute non-ischemic myocardial injury, as has been shown in Mohammed Majid's publication, but also as chronic myocardial injury and also as an acute MI. Now, as far as predictors of the worst outcome with COVID-19 are elevated fibrinogen and elevated D-dimer of more than 1,000, which will indicate worse outcome and definitely need for admission if this patient is being treated on outpatient basis. DIC has definitely worse outcomes and indicates worse severity. And in those type of scenarios, we need to do testing frequently and look at if there's daily rising and then treat patients appropriately. So what are current recommendations for anticoagulant use for COVID-19 patients? All hospitalist patients should receive pharmacologic prophylaxis according to the risk stratification with anticoagulants. On admission, we should change from DOAC to vitamin K inhibitors, antagonists, and also in certain scenarios to low molecular weight heparin and unfractionated heparin. That is very important because it has been shown that DOACs are not effective in this type of scenario. So if the creatinine clearance is low, then we should avoid low molecular weight heparin and use unfractionated heparin. When we have, as I mentioned before, elevated D-dimer and multi-organ failure, then we need to give therapeutic doses of either low molecular weight heparin or unfractionated heparin, depending on the creatinine clearance. You should also consider post-discharge prophylaxis for at least 4 to 6 weeks, because there has been evidence from previous publications that the thrombosis can reoccur in patients that were discharged and relatively stable on their discharge. Now, for troponin elevation, as far as mechanism is concerned, one interesting thing is as far as acute non-ischemic myocardial injury is concerned, that, as we mentioned before, can manifest itself as myocarditis. Also, stress cardiomyopathy, acute heart failure, critical illness can also cause troponin elevation. We have to be aware of that. Acute PE as well, and sepsis. So not all troponin elevations are due to acute MI, and we should pay attention to this. So the question is how to stratify those patients. We know that the increased risk of acute thrombosis is high with those patients that have elevated troponin. And this is obviously in part due to proagulant activity and prothrombotic activity. This is particularly important for patients that have a history of a hypercoagulable syndrome. And we know there are many of them. One of the most common is factor V Leiden deficiency. Now, higher myocardial oxygen supply and demand mismatch due to release of inflammatory markers and catecholamines and hypoxia, acidosis, hypertension, or hypotension can also play a significant role as far as the outcomes of COVID-19 infection. Now, one important thing is, so what to do in patients that have elevated troponin? Do we proceed with imaging? And when do we proceed with imaging? Now, it has been shown in very early experiences from Chinese investigators and also from European investigators, particularly from Italy and France, that were the earliest affected with this condition, that up to 40% of patients with elevated troponin do not have a culprit lesion or culprit vessel, and there was no need for intervention for PCI. So it means that not all patients need it. Now, that also adds importance to how to stratify and triage those patients, because we know that patients that are affected with COVID can actually spread the infection in the cath lab and other investigation facilities, and therefore we should avoid transferring the patients to those units when it's not absolutely necessary, because we also expose our personnel to COVID-19 infection. So we should manage those patients with serial management and risk stratification depending on patient's condition. And those that have rapidly rising troponins, obviously, and classical features of acute MI should be treated accordingly, depending on existing recommendations. But those patients that are relatively stable and do not have increasing troponin levels should be treated conservatively. So thank you very much for your attention.
All right. Thank you, Dr. Fraser. Excellent opening talk for us in this COVID-19 crisis worldwide conference. I thought it was very thorough, and I'm sure that Dr. Halleck may have some comments on this, or one of our panelists. And please unmute yourself when you talk so that we can hear you. Remember to unmute yourself.
Thank you so much, Dr. Fraser, for this amazing presentation. And as always, there's a very rich lecture with very up-to-date information. It's kind of it was kind of troubling sometime in the beginning when you have a troponin and slight rising, like troponin probably 10 times or 15 times. Patients have some atypical, most of those patients have some atypical chest discomfort, and the ECG may not show some non-specific ECG changes. So there are in particular, of course, as you said, that there is so many different reasons for troponin to be elevated. But I think at the end of the day, those end up with myocardial cell damage. Is it because the PE or some other things is only come from the heart, right? I mean, those troponin come from the heart because of PE or because of myocardial injury or ischemia or non-ischemia. I guess there is some cell damage to the heart. When do you start? When do you have to have an echo? Any particular things that you want to do echo? Any criteria have to done an echo, because the risk of doing echo unnecessarily is also a problem.
Right. So this is a very important question, and I think that the echo should be done on admission immediately, so we can look at the ejection fraction and follow it sequentially. Now, the thing is, what we have already experienced at our institution and many other institutions, we do not want to expose echo personnel and
Exactly.
echo interpretation to COVID. So we train our nurses to obtain, in a simple way, echo, and this way we can assess not only the ejection fraction, but we can also see if there is pericarditis or pericardial effusion, which is not uncommon in certain subset of patients, and it could be the cause of ST segment elevation. Now, what is interesting also is there has been a study ongoing in the United States using CT coronary angiography in stratifying and screening the patients, whether they need intervention or not intervention, or coronary angiographic imaging. And it has been in preliminary fashion shown using FFR that is a very reliable way of stratifying or triaging the patients, who needs it, who doesn't need the intervention and angiography.
Excellent. Thank you so much. That's amazing. There was actually, interestingly, we have a many young patient in their early 20s. They have EKG shows ST elevation exactly as MI. I mean, really very significant ST elevation in either inferior, mostly we see it in inferior leads with slight elevation of troponin. Echocardiogram completely normal. And some of them end up with CT angio, just to be sure, because we don't really think that with significant ST elevation and no segmental wall have an acute thrombotic event. And I just looking at the things yesterday, there was quite a few report, a very exact ST elevation criteria for ECG with normal coronary. And CT angio become very handy for those questionable cases, especially if there's no segmental wall motion abnormality. So some kind of myocardial injury mimic the STEMI, but without occlusion of the coronary.
Correct. So it has been shown, and we know that clearly, that COVID affects microvasculature. And actually, when you have a CVA stroke, typically it's not a major vessel occlusion, but a microvascular disease. Similarly, it can happen in the heart and many other organs. So we have to think of that. And actually, ACE2 receptors are probably more abundantly present in microvasculature than in major vessels. And maybe this is the case of what happens to children that develop COVID and have a typical hand, finger effects of COVID. And that's obviously the effect on microvasculature.
That's right. Yeah. Probably there is quite a few questions. Probably we'll try to keep some to the end because we want to be sure that the other speakers kind of be on time. There's quite a few questions about the ARBs for the COVID, other things going on, but I guess we may need to proceed with the next speaker, and then hopefully in the end we have some time to have quite a few questions to be answered. Thank you so much. That's a great presentation.
Excellent presentation, Dr. Fraser. We will have questions at the end. In honor of time, I think we will move on to our next speaker, who is actually Dr. Omar Halak, and he needs no introduction, but I will try to, just tell you all over the world that he is an amazing man, Director of Interventional Cardiology at King's College Hospital, London, Dubai, there in Dubai Hills, and he's the leader of this 40th conference, and he has such a passion for education. So, Dr. Halak, we welcome you to the stage here.
Thank you so much, Annie, for the nice introduction, and thank you for all our speakers to be here, and thank you for the audience to be with us tonight. My talk is cardiac involvement in the COVID, and Dr. Fraser already probably mentioned 60% of my talk. So it makes my life much easier, and I try to go through a few slides I have. Of course, I guess all of us learn, we were learning together on this because there's no somebody called expert in this field in the world. Until now, I don't think there's an expert in this business of COVID and heart or COVID itself. There's a lot of kind of people have more data than others, but things change every day. And we're learning all together day by day of what's going on. And we find out from statistics that COVID, in fact, more on the older patient, especially male, with medical comorbidity, pulmonary, cardiac, kidney, or diabetes and cancer. Tend to be about 20% of patients need to be hospitalized. But vast majority of other patients, about 80%, they are minimally symptomatic or asymptomatic. The one who end up in hospital, about 20% of them end up in ICU. So about total of 4% of total infected people end up in ICU. The cardiac involvement tend to be more common on those patients who have, of course, more inflammatory marker, more of the lymphopenia, acute kidney, elevated LDL, elevated D-dimer, of course, that will show up in elevated troponin. And the mortality rate for overall COVID between 2 to 5%. However, the one who end up in ICU, of course, the mortality is much, much higher than that. So fatality rate for comorbid patient, in the patient, if you have cardiovascular disease, the mortality rate up to 10%. The patient have hypertension, 6%, chronic pulmonary disease, about 6%, diabetic, 7%, and cancer, about 5.6%. So as you can see, it's about 2 to 3 times more, or actually up to 5 times more than the average population. The cardiac involvement, there is really different data. There's quite a few different variation of how often the heart gets infected when patients get infected with COVID. And there's a really lot of different numbers. One of meta-analysis from China for 1,500 patients, they found out about 8%, but there's some report, it shows up to 20%. It really depends if you talk about the whole population or the one who've been hospitalized. Of course, the rate will be higher, and the one end up in ICU, almost all of them end up with some cardiac involvement during their CCU. So on average, about 10 to 20% of hospitalization end up with having some kind of cardiac involvement. What is cardiac involvement? As Dr. Fraser mentioned earlier, it can be myocarditis, myocardial injury with elevated troponin, can be pericardial effusion, Heart failure, right heart failure or left heart failure can end up with cardiogenic shock. Of course, mention about the embolizations, pulmonary embolism, and other systemic embolization. Arrhythmia is common in patient in cardiac involvement of COVID. Also, other embolization causing stroke or peripheral embolization. The etiology or pathophysiology of involvement, as mentioned by Dr. Krager earlier, is something to do probably with the ACE-mediated damage, hypoxia, cardiac microvascular damage. Not sure if there is any macro embolization to the coronary. I don't think that's the case, but micro embolization and micro MIs. It can be in situ embolization, in situ thrombus formation, or probably moved from different parts of the coronary arteries. There is a talk later on by Dr. Kadra about endothelial dysfunction, and it can be one of other reasons for those micro MIs. Systemic inflammation, cytokinase storm, also it can have significant impact on the heart. Matter of fact, most of the patients who have significant cardiac involvement, they have cytokine storm. Pulmonary embolism and right ventricular strain and failure, because it's a combination of not only pulmonary embolism, but also the ARDS and pulmonary involvement and pulmonary hypertension. Viral myocarditis, there's a talk from Dr. Khanna later about viral myocarditis. He will say if they found a virus in the myocardium or not. As far as I know, that virus was not seen yet, but we'll hear from Dr. Khanna later. Now, at the beginning of the infection, the dominant picture is viral response phase, and later start the autoimmune response phase, and both of them kind of play a role in the damaging the heart. Of course, acute coronary syndrome, there's some factors make it supposed to be lower, which is lower air pollution, lower commuting stress, and so on. But there is other counterbalance which increase the likelihood of acute coronary syndrome: psychological stress, social distancing, less leisure walk or exercise, a lot of fear of unemployment, uncertainty. Also, the other thing is not able to come to emergency room. Patients are worried to come to emergency room because worried about catching COVID, and also the ambulance was busy with taking the COVID patients, so sometimes the cardiac patient have to wait longer to get the ambulance to get to emergency room. One thing was reported also that there is sensory neuropathy on patients with COVID. They call it agiosia, where the patient lose some sensation and they lose the pain sensation in the chest and so on. Of course, this report they lose the smell and the taste and so on. But all of those make it more likely to have the event and probably mortality outside the hospital. There is a study from Kaiser from North California, one of the biggest medical group. They have a 21 clinic and 255 clinic and 21 medical center. They review the data from January 2020 to April 14, 2020, comparing the data from a similar time in 2019. And they were reviewing the data for 43 million people, and they found out there was decrease in acute myocardial infarction about 48% during the COVID period. And that was similar for non-STEMI and STEMI. This will be a little bit of debate about what they call non-STEMI. And they found that people who come into the hospital with the STEMI, they have less likelihood to have a pre-existing coronary artery disease and less typical risk factor for coronary artery disease. They have less likely to have a previous MI or coronary intervention. And this is a curve they have. This is a the acute MI in 2020 in orange, and this is in red. The 2020 in red and orange is 19. And as you can see in March, when they have the first late February, when they have the first death from COVID in California, they and the COVID started to go up so high, they noticed that the drop of STEMI coming to emergency room, and that curve continued to drop until now. And comparing to 2019, there was about 46% decrease of the STEMI reaching the emergency room. European Society of Cardiology, they did a very interesting survey. They sent a questionnaire to 186,000 contacts, and 3,000 of them returned the survey from 141 country. And the report says 80% of those responders said there is 65% reduction of STEMI arriving to emergency room. Only 3% they said there was increase of STEMI come to emergency room. And 60% of the responders said the STEMI patient presented later than usual to emergency room. And 40% they said STEMI came too late, actually later than the optimal window for PCI or thrombolytic therapy. And one of the most important risk factor was, or variable was, country total lockdown. Those countries, patients have a much delay to come to emergency room. So there was lower presentation rate and delay in the presentation. And the European Society of Cardiology, they sent a kind of they did a press release regarding the fear of contracting COVID from hospital. They said COVID mortality is 10 times lower than that of an untreated heart attack, and rapid treatment of heart attack work. So if you worry from getting COVID in the hospital, your chance to die at home 10 times higher than dying from the COVID. Now, for myocarditis, as I said, will be Dr. Khanna will talk about myocarditis, and Dr. Kreger mentioned earlier about the mechanism usually associated with cytokine storm, the fulminant myocarditis. I see it in the patients who are younger. They have more of the myocarditis than older patients, and they do respond well to the steroid. We try that for, since early in the course of COVID, because we have nothing else to do, and we kept steroid, and it really worked. That was really early in March, we started using the steroid for myocarditis. There was a risk of using it, but there was nothing else to do. And there was a report of cardiac tamponade with major pericardial effusion. Some of them, they did MRI, but I don't think that was practical to diagnose myocardial, somebody who was really sick with myocarditis to send it for cardiac MRI. Heart failure, the patient come into intensive care unit. There is a study to suggest about a third of them end up with heart failure. Right heart failure also common, probably more common than the left heart failure. And we noted that there is a dilatation of the right ventricle commonly on those patients, and probably multiple etiology, the ischemia, the hypoxia, the ARDS, and the pulmonary embolism. I don't know whether there's something else why make the right failure also more likely to get involved, but probably the pulmonary factor is contributing to worsening and more common right ventricular failure than right on left failure. And for the left heart failure and cardiogenic shock, the FDA on April 6, they issue a guidance for expanding the availability of ECMO for those patients with COVID, and also approve the long duration of ECMO for those patients. And also on June 1st, they approve a right-sided Ambella device for right heart failure. And it seemed to be a very effective way for bridging the patient with right heart failure, especially after able to control the thrombosis and the hypoxia. Arrhythmia is common with heart failure, with the cardiac involvement of COVID, and the mechanism is multiple. It's cardiac injury, as mentioned earlier, with elevated troponin. Almost everybody coming to intensive care unit, they have elevated troponin and D-dimer. And so that indicator of some myocardial damage and triggering arrhythmia. Of course, hypoxia, acute systemic inflammation, in addition to, of course, all of us know about the story of medication and the chloroquine story. I guess I have a slide on that one. There is, of course, there is a estimated about 16% of patients hospitalized end up with having arrhythmia. And it was noted that the patient with a COVID involvement of the heart, they have hypokalemia, and it probably due to the effect on the RAS system. Cytokine storm, where there is severe immune reaction in the body, I think is more common in young patients. There's too many cytokines too quickly released to the blood, and that end up with complication for multi-organ failure associated with higher risk of having a stroke or MI or myocarditis, heart failure, and kidney failure, and all other multi-organ damage. And this is a worse outcome. They do respond somewhat well to steroid, but the mortality rate is still high. Patients become tachycardic, tachypneic, diaphoretic. All of them have elevated D-dimer, and many of them end up with renal failure, requiring renal replacement therapy. As mentioned earlier, thrombosis everywhere, including the lungs, and it's not uncommon to see actually macro pulmonary embolism, but probably all patients come into intensive care units, they have some elevated D-dimer, indicating some kind of probably microembolization either to the lungs or thrombosis somewhere else. But the thrombosis is very common, and Dr. Kreger mentioned the benefit of anticoagulation. And as he mentioned that NOAC does not work in these patients. Matter of fact, I have a patient who was put on NOAC in COVID, but after discharge, she had a superficial vein thrombosis. I don't know if it's related to using the DOAC, or it was kind of weird case that after she recovered completely from COVID, she developed vein thrombosis, and he has put her on Clexane, low molecular weight heparin. So adding to the problem to the patient with ARDS, they will have acute thrombosis for pulmonary and microembolism and macroembolism, and of course that will worsen their course. A stroke, as mentioned earlier, also it can be ischemic stroke. About 15% of patients with COVID end up with an ICU, and there is a 6% they have hemorrhagic stroke. Probably the transformation of the ischemic stroke or just something else going on, we don't know yet. And there was a report of cerebral venous thrombosis in patients with COVID. All of us, we know about the chloroquine story with COVID. Initial small report, so it's beneficial to the patient with COVID, and especially with combination with azithromycin, but turned to be that will cause, as we know, increase QT prolongation, and there was increased mortality after using that chloroquine. And then FDA announced that this should not be used except for under a research protocol. There was a lot of political things about the chloroquine, and as all of you know that President Trump, they said, well, this is a magic medicine going to help the COVID, but later on turned to be, it is very dangerous to the patient. In summary, during COVID pandemic, more people will die from cardiovascular disease than from COVID, probably 10 times more. Cardiovascular disease or risk factor for cardiovascular disease, hypertension, diabetes, and so on, they increase the risk of getting infected with COVID, and they will have worse outcome. hypercoagulability state with thrombosis, embolization are common in hospitalized patients with COVID, acute coronary syndrome, myocarditis, pericarditis, arrhythmia, heart failure, and shock, all possible complications of COVID. Cytokine storm associated with multi-organ damage and may response to steroid. Thank you very much.
Dr. Halak, thank you so much for that all-inclusive overview of COVID in the heart. And I've given the leaders of the conference a lot of time to talk, and now we're going to be a little bit more, I'm going to rein in everyone who goes, you get 10 minutes to really educate us. And so we thank you for all of that, our great leaders. Now we're going to go to our next set of speakers. The next speaker is Dr. Khanna. Dr. Khanna, I met him at our wonderful conference there at 4TS. He's a leader in India with the Apollo group of hospitals, and he has his own conference there in New Delhi, I believe. He has a wonderful talk for us about COVID and myocarditis. Dr. Khanna, welcome to our stage. Please unmute yourself, and remember, everyone take 10 minutes, and we may have to hold questions to the end. Let's see how it goes. All right, Dr. Khanna.
Okay. Can you hear me?
Yes, we can, sir.
Okay. Thank you, Annie. Thank you, Dr. Halak and Dr. Fraser. It's been a great pleasure to be invited and to be speaking in this conference. And very happily, it's on the topic of COVID. Just to, I would have a request that I would have to leave after my presentation because my own partner is down and admitted in the ICU with COVID-19, and she's got a daughter who is 1.5 years old. And I need to go and attend to her. And another of my colleagues is also a cardiologist in ICU and is going to be on quarantine. It is a very bad disease, and it's actually we are the most vulnerable persons to actually be dealing with this complication. And the stage is already set by Dr. Fraser and Dr. Halak. About 30% of patients who have COVID actually come to the hospital with severe cardiovascular involvement, which could be myocarditis, acute coronary syndromes, arrhythmias, pericarditis, myocarditis, or venous thrombosis and thromboembolism, apart from strokes and drug-induced issues. So this is a very common disease, and as Dr. Halak said, if you don't treat these, you would probably have more chances of dying because of cardiac issues of COVID rather than COVID itself. I'll keep my topic very small, and we'll just go with a small case report and a brief about myocarditis in COVID. We have an experience now of treating 1,200 patients in our hospital, and India, as you know, is the fourth largest in terms of numbers in the world, and every day we are getting about 50,000 new patients in the country, and all the hospitals in the country are actually facing this brunt of disease. Now, coming on to the COVID-19 in patients with cardiovascular disease, this Dr. Halak has already alluded on this. Reports from NSC of China reported that 12% of patients without known cardiovascular disease had elevated levels of troponin and had cardiac arrest during hospitalization. So this actually led to a suspicion that there could be a direct myocardial injury or arrhythmias leading to this death. And people who died from COVID-19 reported by the NSC, 11.8% of these patients did not have underlying cardiovascular disease, but had substantial heart damage on autopsy, and their cardiac troponin levels were increased, and they had cardiac arrest during hospitalization. So again, this actually set the stage that there could be a direct myocardial infarction, myocardial damage by the COVID-19 virus. And this was substantiated by the autopsy reports from Germany. So this led to a suspicion that actually this could be direct myocardial involvement leading to myocarditis or cardiomyopathy. And this was again substantiated in the United States. In some areas, they found higher incidences of the normal of myocarditis, myopericarditis, and also coronary vasculitis leading to syndromes like Takotsubo, cardiomyopathy, and also Kawasaki disease. So how how the SARS-2 COVID virus binds to ACE2 inhibitor is this has been explained by Dr. Fraser. And what it does, it directly binds to the ACE2 receptors, which are highly expressed both in the coronary endothelium and the myocardium, apart from the lung tissues as well as the brain. And there is also an increased pro-inflammatory cytokines release, and this leads to a systemic inflammation. Both together actually damage the myocardium and depress the myocardial function. And this leads to a severe form of myocarditis, pericarditis, or cardiogenic shock in these patients. Again, the SARS-CoV-2 virus binds to the ACE2 receptors following the activation of spike protein by TMPRSS2. And what happens is the myocardial injury is, it gets into the myocardial cells, and it leads to intense inflammation. And this is sort of evidenced by increased in cardiac biomarkers, which was recognized as very early in the Wuhan epidemic, as early as in January. And the myocardial injury can actually present like a myocardial infarction. Again, as Dr. Halak said, and Dr. Fraser said, 30% of the patients would have a ST elevation MI mimic. When you do their coronary angiogram, find that they have non-obstructive thrombotic lesions of coronary artery. And this is because of the myocardial injury in association with coronary thrombosis. And we can have, normally we have increased inflammatory markers like increase in IL-6, dimer, ferritin, and LDH. And this also is accompanied by increased levels of high sensitivity cardiac troponin, which was seen in the initial reports of the first 41 patients of COVID-19 in Wuhan, where 5 patients had raised high sensitivity cardiac troponin levels more than 28 micrograms per ml. And again, it was seen that patients who went into in ICU and required ICU support and ventilatory and cardiac support actually had much higher levels of these markers, both the creatinine kinase and troponin. So again, the emphasis was that there is a direct myocardial injury in these patients. Of course, the myocardial injury could be increased and substantiated by cytokine storm, by acute coronary syndrome because of acute coronary occlusions, by ACE-mediated infiltration directly into the myocardium and leading to myocarditis, and sometimes also by the drugs which we are using to treat this infection. So with this background, I'm presenting one representative case about, just to give you a brief, about 6 to 7% of the patients in our series actually had myocardial involvement in terms of cardiomyopathy or myocarditis. This is a 35-year-old male who presented with fever, which was 102 degrees Fahrenheit for 2 days before admission. Also presented with shortness of breath for 1 day with a low saturation of 89%. And the patient had atypical chest pain, which was almost typical of pericardial pain. And his RT-PCR for COVID-19 virus was positive. This was the ECG, which showed ST elevation, suggestive of pericarditis, and also we have ruled out acute coronary syndrome in these patients because these were generalized changes in all the leads. And in terms of the biochemical and the blood labs, the CBC was normal, the CRP was 20, the D-dimer was 886, the interleukin 6 was 156, and HS-TROP was 5,500. If you see, we did a transthoracic echo in an emergency department. We have a dedicated machine for doing these COVID patients and a dedicated personnel to do the COVID echocardiograms. What we find here is the LV function is depressed and there is a pericardial effusion. And this is the four-chamber view showing the same with depressed LV ejection fraction, generalized global lipokinesis, and pericardial effusion. The patient was actually treated by decongestive therapy, also had a routine CT scan, which showed infiltrates in the lungs, typical of COVID pneumonia. And also the MRI, which was done a little later, not at the time of the admission when the patient was slightly better, which shows inflammation in the myocardium and also uptake in the myocardium, epicardium, and pericardium.
Dr. Khanna, 2 minutes, please.
Yeah, sure. The patient was treated by decongestive therapy, which is standard, was also treated by dexamethasone and remdesivir. And this was the echo, which was done after day 7, showed a slight improvement in the myocardial functions. And the patient had maintained the saturation on 1 liter of oxygen above 95%. So these are representative patients. Most of them, if diagnosed early, can actually be treated aggressively and can have good outcomes. But some of them actually decompensate and require left ventricular assist devices, and sometimes they have cardiac arrest and they die with intractable cardiac arrest, intractable failures and recurrent cardiac arrest. In short, the way we treat is if you have COVID-19 patients who are suspected to be having myocarditis, we must do a routine ECG, enzymes, inflammatory markers, and also transthoracic echo. If the patient is stable, the patient can have a CT coronary angiogram or a contrast or a cardiac MRI. And if the patient cannot tolerate that, we have a presumptive diagnosis of myocarditis and treat them with the usual therapy. There should be no reservation in treating these patients as we treat general patients in terms of heart failure and cardiac assist devices. Most of them do very well. And it's not good to use QT prolongation drugs which can do can increase the QT interval, especially antimalarials like chloroquine or drugs like ritonavir, lopinavir, or azithromycin. And many a times we also avoid NSAIDs because what they do is they increase the sodium retention and increases the heart failure. We tend to avoid this and also tend to avoid negative inotropic agents. Thank you very much. I'm going to be stopping here for the paucity of time. And I also need to take the permission from the chairperson, Dr. Fraser, and Dr. to actually go and attend our colleagues who are admitted in the hospital a few hours back.
Dr. Khanna, we thank you so much for that wonderful presentation. Unfortunately, we don't have time for questions currently, and we wish you all the best, and we pray for your colleagues there in India. So the next presenter will be Dr. Abdullah Shahab, and I believe he is there with us. Dr. Shahab, you can get ready. He's an amazing educator there in the UAE, and we're so happy to have him with us. He's also, I believe, the chief editor of the Emirates Medical Journal. And so many of our 4TS data will be in there, we hope. So Dr. Shahab, take it away.
Assalamualaikum. Thank you very much, everyone. And great to see you, Dr. Umar, Dr. Bejar, and everyone. All the colleagues healthy and good to see you really virtual. I think everyone's virtual nowadays, so I think it's nice to see you. Right, as the chief editor of the New Emirates Medical Journal, I had the privilege to really meet most of the societies in the country, starting from cardiac society to intensive care, ER, family medicine, microbiology. I have a great kind of experience of what they've been doing in the country. I'll maybe discuss that later on, but I give you a glimpse of what a case of acute coronary syndrome, which represents type 1 among the COVID in the country, 50% type 1. 15% of our COVID cases were young, and they had a lot of thrombus burden, which really I think is made everyone to know, to go to the basics, how to manage that patients. And then we had, of course, other type, which we will discuss at the end, inshallah. So I'm going to take you through a very simple case. Let's see. So it's a 55 years old, diabetic, hypertensive, dyslipidemic. You see, these patients are at risk. We know, we already, Dr. Umar, Dr. Chris mentioned, these are the patients who are, if they get COVID, they have very bad outcome. And this is happened with this patient. Basically, you know, he said he developed a kind of a short of breath for a week, and then came with chest pain for 2 days. And, you know, if we look at his ECG, you can see it's still elevation. You don't know, is this really right coronary, LCX, something else going on? We don't know. And at the beginning, this was actually in March, you know, this case was in March. You know, some of our experience similar to China at the beginning, we used to take patients like this, thrombolize them because, you know, we worried every patient, especially like this patient, you know, potential of having COVID-19. But anyway, this hospital say, no, we will go with primary PCI. And this is what was the case. This patient had a chest X-ray. You can see, again, consistent with you know, that concern we have, COVID-19. So this patient, basically, you know, we worried about his saturation. He was electively intubated because this hospital was ready for, you know, pathway for COVID and or non-COVID cases. So this electively intubated, taken to the hospital, to the cath lab, you know, and lab, you know, this had Brilinta actually, this patient, and loaded with heparin and aspirin, radial axis, and during this is right coronary, you can see it's free, I mean, a bit of disease actually, you can see like 670, you know, ostial there, and not really, we don't think that's the culprit. So we looked at the what's this? I can't, okay. You can see is that LCX is thrombotic, you know, so it's fresh, some plaque ruptures. That's the reason. So straightforward, you know, wired, ballooned. You can see lots of thrombus going downstream here. Then it was stented with 3.5 by 20 regulating stent, and you can see lots of thrombus going downstream. And you can see previously, and this was the result. So patient had during this procedure, just to know, blood pressure gone down, so become like cardiogenic shock, not responded to dopamine, dobutamine. He had to have intra-aortic balloon, which, you know, we don't know the importance of that, but anyway, we don't use it actually anymore, but that we had to do that in that case. Patient then, after, you know, came back, the result same day was positive, COVID positive. Anyway, that everyone taking their precaution, PPE was there, we had the pathway, everything was in the right way. Patient was extubated after 3 days, then actually deteriorated again. Patient, you know, shown to have COVID-19 pneumonia with respiratory failure. After, you know, this was 23rd of March. On 29th of March, he had the echo. You know, that's a delay of echo happened because, again, people are worried to, you know, not necessary to do echo unless it's, you know, the patient is getting worse. So we did the echo, injection fraction was about 35-40. We were not intending to do right coronary because that was, we said, medical treatments enough for that case. Patient, unfortunately, you know, the troponin went to like 700 and the CRP 200, fibrinogen high, then actually deteriorated. They, you know, after that, you know, remained he intubated again. He remained in ICU for about 1 month. Tried every medication we use for COVID, you know, all these antibiotics, antiviral, nothing respond. Patient actually at the end, we lost the patient. So this was an example of, you know, of a COVID, which was a bad outcome. But our experience in UAE of the acute coronary syndrome STEMI has been really great. Most of them did well, but I had to give you just an example of, you know, bad end, but this is the life. So that was my simple case. I have other cases, but I don't think it's time for that. So thank you very much.
Thank you, Abdullah. That was very good case, and kind of we see that you did a great angioplasty, but unfortunately the patient, I think, is too sick from COVID itself. The lungs look like very bad, and he's really very sick regarding of his heart condition. Thank you for the presentation.
Thank you, Dr. Shahab. I think for our 3 teachers here who have just presented, or 4 teachers here, there is a question. Does history of previous DVT and PE in a young patient add to the risk of cardiovascular complications of getting COVID-19? I'm getting questions here on the Q&A, so I just thought I would present one of these to you all. Would one of you like to answer that? Dr. Shahab.
Sorry, history of DVT and PE put patient at risk of what?
Patient.
COVID?
Young patient add to the risk of cardiovascular complication of COVID-19.
You know, we've seen this. I mean, I'm sure all of you have seen that. I said 15% of our patients with acute coronary syndrome had other multi-organ. One of them is the thrombosis here and there. Of course, if they have a DVT pulmonary embolism, I'm sure it's make the outcome worse. That's what I.
Yes.
Yeah, especially if they have the predisposed to DVT and PE, if they have hypercoagulability state to start with, the COVID infection, they will make them more hypercoagulability, and probably they will be at higher risk of having embolization, I think.
Exactly.
Thank you both. All right. I think our next speaker kind of pulls it all together there with what is happening at the endothelium. So talking about endothelial dysfunction, Dr. Walid Kadro, Director of the Golden Center for Advanced Cardiovascular currently, and going to talk about endothelial dysfunction in COVID. Dr. Kadro, take it away. And you need to unmute yourself, sir.
Me now?
All right, now. We cannot hear you very well.
Can you hear me now?
That's better. Can you increase that volume somewhat?
Okay.
We're all the way in Texas, so we need a little volume.
Yeah. Can you hear me now?
Yes.
Yeah.
Yes,
Okay.
better.
Let me share my screen now. Okay, good evening, everybody. Let me thank all the organizers, especially Dr. Halak and Dr. Krager for the nice invitation for this nice symposium to cover about COVID-19. I'm happy that I'm taking off my hat as an interventional cardiologist and putting a new hat as a vascular biologist, and we'll try to cover the topic of endothelial dysfunction. Just let me put on the slideshow. Okay. So everybody knows about the endothelium, about the vessels, and every vessel has adventitia and media and has the endothelium. And you know the endothelium is only one layer, but has a lot of function. So the main function of that, apart from protection and maintaining the good flow, it works as an anticoagulant and prevent the formation of in situ clots, and also work as a vasodilator through the production of an important substance called nitric oxide. And the nitric oxide is really synthesized in the endothelium by converting the arginine to citrulline and adding oxygen, and thus create the nitric oxide. And the nitric oxide has a lot of important function. It promotes vasodilation, it increases arterial compliance, and cause positive remodeling and dilation of the vessel, and also inhibit a lot of bad things like smooth muscle proliferation, and prevent apoptosis of the endothelial cell, prevent thrombosis, and prevent platelet activation. It also prevent the secretion of the tissue factor when it's intact. But however, when it's the endothelium is really damaged, it releases tissue factor. Also, the nitric oxide prevent inflammation and production of cytokines. So this is the effect of the nitric oxide production through the enzyme called endothelial nitric oxide synthase. And after the production of nitric oxide, it has a lot of good things that promote laminar flow, prevent adhesion of all leukocytes, and prevent activation of platelets, and also work through cyclic GMP for production of the substance that cause smooth muscle relaxation. And with that, this is the one of the tests that I used to do in the CAS lab when I was a fellow. And that's where, this is the baseline, and you see that the vessel is not dilated by really giving acetylcholine infusion, which work through production of nitric oxide cause significant dilation of the circumflex artery. However, if the nitric oxide is not really bioactive due to damage of the endothelium, we'll get all of those things inactivated. So we are not preventing adhesion. So there is more leukocyte adhesion. There is less oxygen delivery. There is increased platelet activation, and there is no vascular muscle effect. And with that cause vascular muscle contraction and spasm of the vessel. And really, the endothelial dysfunction predict cardiovascular mortality. This is a small study that evaluated the patients who were going for vascular surgery, and they did endothelial function through the brachial artery ultrasound, and found that the people who has normal vasodilation in response to acetylcholine has almost fourfold protection from cardiovascular event compared to the people who has really a bad response to dilation. And there is too many studies, most of them are really positive that endothelial dysfunction predict cardiovascular event. So how do we get endothelial dysfunction? And the most important thing is the oxidative stress, because if we have really a superoxide and active oxygen species, reactive oxygen species, when it really work and interact with nitric oxide, it produces this substance which is nitric superoxide. And this chemical activation is really quite fast, happen like a diffusion, and the rate constant is really high. And a lot of things cause this endothelial dysfunction and impair nitric oxide bioactivity. Everybody knows about hypercholesteremia, smoking, diabetes, and hypertension, and coronary artery disease. Now, how this can we interact between the reactive oxygen species and nitric oxide? We know nitric oxide causes vasodilation, platelet inhibition, smooth muscle quiescence, and vasodilation, normotension, and prevent proliferation. However, if we get reactive oxygen species, we get vasoconstriction, thrombosis, smooth muscle hypertrophy, and hypertension, and endothelial cell damage or death. And we know they work against each other. Now let's talk about reactive oxygen species. And we know that this oxygen, regular oxygen, if we add an electron to it through an enzyme, which is quite common in the white blood cells, the enzyme called NADPH oxidase, and that's produced really superoxide. And let me put this red dot to indicate that's really a radical and a harmful substance. And if we add another electron, we'll get the hydrogen peroxide. And if we add another electron now, we'll get reduction and we'll get the another really harmful called hydroxy radical. And finally, if we add another electron, we'll end up with the harmless substance of water. Now, how our body protect us from that? There is a lot of things. Now we have an enzyme called superoxide dismutase, which has 3 subunits, one in the mitochondria, one in the extracellular matrix, and one inside the cytoplasm. And the cofactors for one is zinc, the other cofactor is copper, and the third cofactor is manganese. And this enzyme take this superoxide and bring it back to oxygen and hydroxyperoxide, which is less toxic substance, but still it works as a killer in the white blood cells. Now, the other mechanism—
Dr. Khadr, 2 minutes, please. 2 minutes.
The other mechanism are really the substance of glutathione, and if reduced form, it's really converted to an oxidized form, and that caused this hydrogen peroxide to be converted to water, and through an enzyme called glutathione peroxidase. Now, this can recharge again by another reducing enzyme called glutathione reductase. Now, with that, also there is another prevention mechanism through an enzyme called catalase, which really take this hydrogen peroxide and convert it back to normal oxygen and back to water. This is the normal things. Now, what's happened if we get increased oxidative activity in obesity, hypertension, in type 2 diabetes? Now we'll go back to what happened here in our COVID patient. We have oxidative stress, and we reviewed that, and this concentrate on this, and we'll find that now there is no protection because of the exhausted effect of the superoxidase dismutase and this glutathione peroxidase. And what will happen, we know that there is angiotensin 2, and angiotensin 2 is really converted to good substance through an enzyme ACE2. But however, this angiotensin 1,7 also work to suppress the nitric NADPH oxidase and prevent the production of this bad substance, superoxide radical. However, if we get the SARS-CoV, yeah, this is the last slide. If we get the SARS-CoV-2, we'll get more inhibition of this ACE2. So there we have now double inhibition. That means increased activity of NADPH oxidase and increased production of superoxide radical and increased oxidative stress. So this is the summary slide of hypothesis, how we get this bad coagulation. We get SARS-CoV-2, and that will get decrease in ACE2 activity after the connection, the virus interact with this receptor, and this will get increase of angiotensin 2 and decrease of angiotensin 1,7, and that's lead to increased oxygen, reactive oxygen species, and this radical substance, and that's cause endothelial cell dysfunction, and with that we'll get increased production of bone volume factor from this damaged endothelium, and that will end up with this thrombosis. And that's the mechanism of endothelial dysfunction and why we get increased thrombosis with COVID-19.
Wow,
I have a lot of studies, but I think I did reach you the message, and thank you very much. I'll be happy to get any question.
Thank you, Dr. Khadro. That was amazing. We all needed to remember about all these pathways and endothelial dysfunction. Unfortunately, we have no time for questions right now, but later, hopefully after we finish all of this. Thank you so much, sir. Our next speaker is Dr. Lauren Barron, and she's hailing from the United States, from Waco, Texas. So a great friend of mine who is the lead professor of medical humanities there at Baylor University. I'm honored to be affiliated with her, as well as Dr. Halak and Dr. Tamkeen, all, and Dr. Hussein, who's with us, all adjunct professors there teaching medical humanities with her. Dr. Barron, please take it away.
Good morning. Can you hear me okay?
Yes.
Greetings from Texas, and I'm so thankful to be able to be here with you today. I am going to be talking about bridging the art and science of training physicians. And I have here a picture of my students on a very important bridge in Waco. It's a suspension bridge over the Brazos River. It's called the Brazos de Dios, the Arms of God. So that's where I'm hailing from actually this morning. So what is medical humanities? Well, it's a bridge between the art and science of medicine that we've been discussing this morning. I also describe it as the best of a liberal arts education with the medical focus. And I also like to say that we're trying to turn medical students into human beings before their medical training turns them into gods, robots, or zombies. And we all have met doctors like that. So that's when I say medical humanities, that's what I mean. I want to start with Sir William Osler. Some of you may be familiar with. He's famous for his command of the humanities and his insistence that doctors become familiar not only with the science of medicine, but with the humanities as well. And he's considered one of the most influential physicians and one of the most influential speakers in the English-speaking world. And as I say that, I'm very conscious that Western medicine is built on a foundation handed to us from our Islamic medical brethren. And I want you to know that I teach my students about Razis and Ibn Sina and Ibn al-Nafis, who we know was before Harvey in discovering the circulation of the heart. And so even though I'm talking about humanities from the English-speaking tradition, I want to just recognize that that we're building on a tradition handed to us from your part of the world, and I'm afraid that goes unrecognized. So I wanted to pay my respects today. This was Dr. Osler's bedside library for his medical students. He said, start at once a bedside library and spend the last half of the day in communion with the saints of humanity. And these are the works that he recommended. You can see Plutarch, you can see Shakespeare, the Bible, Don Quixote, some of the classic Roman and Greek authors. And so this is what he recommended in addition to the scientific training of his students. This is a speech that he gave called The Old Humanities and the New Sciences. And he talked about for physicians to be properly educated to practice their art, knowledge of the science of medicine must be supplemented by familiarity with the humanities. And he also called humanities and science twin berries on one stem. And he says that grievous damage has been done to both in regarding the humanities and sciences in any other light than complemental. So what he's saying is we have to view the humanities and sciences not as in competition, but as complemental to each other. I also want to mention, if you'd like to do more reading in this area, Dr. Edmund Pellegrino, who said it the most succinctly, that medicine is the most scientific of the humanities and the most humane of the sciences. So as physicians, we are right at that intersection of science and the human experience. And so, so this is what I spend my life teaching my students, that we must excel and we must know as much as we can in the sciences, but the humanities is another way to know about, if we're going to take care of human beings, we need to understand human experience. And how do we do that? We do that through the humanities. So in this excellent conference that we've had the privilege of attending this morning, we've been looking at COVID through a scientific lens. What is science? We think of objectivity. We think of facts. We think of replicable procedures. We think of universal rules that apply to all of our patients, things that we can generalize. And science helps give us that biophysical understanding of disease process. But we can't forget the humanities as another source of wisdom and knowledge. When we think of the humanities, we think of subjectivity, we think of stories, the stories that we all listen to of our patients that are idiosyncratic, that are individual, that are unique, that are particular. The fact that multiple truths can exist simultaneously, multiple perspectives. And the humanities can give us an understanding of the biopsychosocial and spiritual understanding of illness as compared with just disease. I want to mention T.S. Eliot, a famous English author, who says, where's the life we've lost in living? Where's the wisdom we've lost in knowledge? Where's the knowledge we've lost in information? I would subject to you for your examination that I think what we want most in our physicians, we want to be wise. And science can help us with knowledge, but for wisdom, we need something even bigger than science, and science is big. My corollary that I've added is where's the information we've lost in data, and where's the data that we've lost in noise? And I think the humanities can help us cut through the noise, cut through the data. One person has said that stories are data with a soul. So I love that we need to think of our stories as well. I want to mention Dr. Eric Cassell, whose writing has been extremely influential. Dr. Cassell was one of the first to talk about the importance of approaching our patients, not just as patients, but as persons. And I want to quote here an excerpt from one of his books that I think are so important. Scientific doctors, that's us, who lack developed personal powers are inadequately trained. Another way of wording this is to say that in addition to the tools placed at their disposal by science, which we've talked about today, doctors are themselves instruments of care who must be refined by knowledge and training to be maximally effective. So we've got the tools placed at our disposal by science, but he goes on to say, it's universally accepted that a doctor's education has to continue for a lifetime, just as we're doing today, to keep abreast of advances in medicine. It's less well known, but equally important, and I want to emphasize this, that a physician continually work at refining the instrument of medical care that is himself or herself, the personal power and effectiveness essential to the very best medical care. So we ourselves, I was taught to use a stethoscope as we all were. I was not taught that I myself am the instrument of medical care and that we have to work on our personal powers to be the very best that we can. Just science alone will not prepare us well enough to take care of our patients. I'm happy to say that Dr. Eric Cassell is alive and well. He's retired from his practice in New York City. He's 90 years old. He's actively writing, and he would love to correspond with any of all of you. He's not hard to find on the internet. These are some of the books that I would recommend to you. And I want to point out, as I had to point out to him because he wrote it so long ago, The Place of the Humanities in Medicine was actually his very first monograph that he wrote. So he talks about the significance of the humanities there, and these are among some of his excellent books. I want to quote here the journalist and thinker David Brooks. He came to Baylor University and he made a statement that stopped me in my tracks. We can only act in the world we see. Now, if the only world we see is the world of reductionist science, we're missing out on a massive part of experience. So if we only train our medical students to see at the level of atoms, at the level of molecules, at the level of enzymes, all of which are so important and we've talked about today, we've also got to teach them to see in a much bigger world. And I will begin to close here with this beautiful analogy that Dr. Cassell wrote. It's common to confuse the question we're asking with the method that we use to get the answer, but the method determines the answer. Now listen to this. And I love this because he's using the rose, which is such an important symbol all across the world for so many of our cultures. If we're asked to describe a rose and we're given only a ruler to do it, the picture of the rose that emerged would be solely in terms of inches. The picture would be true, but incomplete. If a ruler were our only way of describing things, we wouldn't even know that the picture was incomplete. So I think this is a beautiful analogy of how we do need science, we do need statistics, we do need these things, but it doesn't give us the complete picture. So medical humanities that we teach at Baylor and all over the world mainly involves these 4 areas, which I won't go into at length, but we have courses in all of these areas. And I believe that all of these things help inform our understanding of medicine. And I will end with this quote from Dr. Osler, that from over-specialization that we all know we can be tempted to, scientific men are in a more perilous state than the humanists from neglect of classical tradition. We cannot neglect our classical tradition. We must think of building on this. And what he says is when all these studies, the humanities and the sciences reach the point of intercommunion and connection with one another and come to be considered in their mutual affinities, then I think, and not till then, will the pursuit of them have a value. So we must remember both parts of our training. And I thank you very much for your time and attention. And I'm especially moved by Dr. Hollick's comment at the very beginning of the conference that this COVID, this experience has affected our health in general and our hearts in particular. And I'm very honored to be among physicians and colleagues who spend their lives in pursuit of heart matters. Thank you very much.
Thank you so much, Dr. Barrenford. This is a great presentation. It gives us a different angle of practicing medicine, which is a very important one. And thank you for this great presentation. We are so pleased to have you with us tonight.
Thank you.
Thank you so much. Now we'll continue on with Dr. Fekri Eldib, and he will be speaking about pulmonary embolism in COVID-19. Dr. Eldib is there in the UAE, and we welcome you, sir.
Thank you so much for your kind introduction. Just to make sure, is my voice clear?
Yes, perfect.
Great. First of all, I would like to thank Dr. Omar and Dr. Kreger for the nice invitation. I have been part of this meeting since the beginning, and I have the honor to participate with cases every year. It's very nice gathering. I have to say that I enjoyed the previous presentation. Dr. Perron was amazing, and thank you very much for reminding us to be human before being doctors. That's an amazing message, and I enjoyed this presentation very much. It's my pleasure to share with you today an interesting case of heart thrombosis in a patient with COVID-19, which I had to share her treatment last April. April was a very tough month for me because we are 3 interventional cardiologists, and 2 of my colleagues were hit by the virus. So I was alone for 1 month, and I had to take care of the whole cardiac patients, the whole hospital for almost 3 weeks. This lady was unfortunate. She was a 32 years old lactating woman who was admitted on the 3rd of April because of low back pain and intermittent vomiting for 2 to 3 days. She was admitted actually under general medicine, and she was investigated for her low back pain and for the vomiting. And she developed suddenly shortness of breath at rest and with mild effort in her room. And that's when I was involved in the case. On examining the patient, she was in good shape. Febrile, the heart rate was 68 per minute, blood pressure was fine. She's BMI was 26, respiratory rate was 20. So I just did an ECG, an echo to get some idea about her heart. And at the same time, a sample for coronavirus was taken. And at that stage, the internist did an MR spine who found suspected bone metastasis with unknown primary, and MRI brain was within normal, and she had lumbar puncture, which she showed some improvement of her lower back pain after. So this is the lab of this patient. She had quite high white cell count, the neutrophils were high, and the lymphocytes were low, and hemoglobin was quite low, 8.5. The CRB was high, D-dimers were high, and S-ferritin was high. And that was the reason why I requested the coronavirus test, because the lab is suggesting the presence of corona. The ECG, to start with, was not showing any significant changes, as you could pass it as normal. However, when you read the echo, I think you can appreciate here this clot in the right ventricle. So that was a striking finding. We found this clot, and you can also appreciate that there is some pericardial effusion here with some indentation of the right atrium, some effusion also on the other side of the heart. We recorded this, and I immediately shifted the patient to the ICU after I gave her 5,000 units of unfractionated heparin. And she was started on enoxaparin 60 milligram sub-Q twice daily. And I ordered CT pulmonary angio to rule out pulmonary embolism, which would not be detected. And later on, the COVID-19 RNA PCR came back positive, so the picture was clear that this patient has COVID-19 beside her metastasis. So at this stage, we formed a multidisciplinary team of the oncologist, pulmonologist, the intensivist, and myself, and we're managing this patient on daily basis. Eventually, an adenocarcinoma of the lung was confirmed to be the primary source, and the patient, has COVID-19 with RV thrombosis and pneumonia. And she was treated by colleagues' respective problems, the adenocarcinoma. The pulmonologist was taking care of the pneumonia, and the intensivist, was doing his part. I did some serial echoes to just monitor the size and the fate of these thrombus to make sure that it is under control and it won't cause any significant or major pulmonary embolism. She was continued on sub-Q anticoagulant all this time, and my colleagues treated her with multiple IV injection. You can imagine there are some antibiotic and some dexamethasone, methylprednisone. And after 1 month of anticoagulation, almost I had to repeat the echo, and at this time, the clot completely disappeared. Maybe some remnant here if you might, suspect, but definitely the clot is not the same like how it was before. So I decided to continue the anticoagulant for some time, and my role here was limited, so I was just called on demand. The patient unfortunately worsened her condition from the pulmonary side, and she had to be intubated and mechanically ventilated, and she underwent treatment for a long time, and then her family elected to evacuate her by air ambulance to a local hospital in her country. So I don't know what happened to her after that, unfortunately. So I come here to the discussion. As discussed by many of my colleagues before, the proposed mechanism for COVID-19 induced thrombosis include a disease-specific hypercoagulable state, cytokine-mediated diffuse microvascular damage, and in some cases, reactive thrombocytosis. The risk of thrombosis and pulmonary embolism can further be compounded by some factors like obesity, advanced age, and hospitalization-related embolization. In my patient, the patient had elevated C-reactive protein, elevated D-dimer levels, with no other risk factors for pulmonary embolism. Therefore, COVID-19 related hypercoagulable status was assumed to be the possible cause of thrombosis in the right ventricle in this patient. So to conclude, it is imperative to follow prophylactic measures for avoiding venous thromboembolism in COVID-19 patients. Sudden deterioration in respiratory status that is not explained by significant radiological changes in the lung field, and especially in conjunction with high titers of D-dimer, should raise suspicion for pulmonary embolism. More studies are needed to determine the utility of therapeutic doses of anticoagulant agent in high-risk patients with COVID-19 as a prophylaxis, before it happens, as a matter of fact. You can imagine, I think you were familiar with this, we had to, every time doing a procedure, to be completely covered like this to protect ourselves from this dangerous infection. And we did our best to protect our patient. And I would like to thank you very much for your attention. And I think we'll leave the questions till the end, as the time is running fast.
Yes, thank you so much, Dr. Al-Deeb. We appreciate that wonderful talk, and we will save questions for the end. Right now, we're going to bring Dr. Kowatli. Dr. Kowatli is consultant pulmonologist, critical care medicine, invasive pulmonologist at King's College Hospital, London, Dubai. And he'll be presenting about, I think in generalities, about COVID complications. Go ahead, sir.
Well, thank you very much. Okay, let me get it here. Okay. Okay, well, before we start, thank you very much for inviting me, and Bismillah ar-Rahman ar-Rahim. Well, as you know, that COVID, the coronavirus was discovered years ago in the 50s. And this is Dr. June Almeida, who discovered the virus is somebody who has upper respiratory tract infection. And she submitted at that time the picture of the coronavirus, but it got refused by the peer review. But finally, she get it approved and get published by British Medical Journal. And we know that with this COVID-19, we are seeing too many different things. For the first time, I've seen that articles in good journal like Lancet and New England get removed because of not well done studies. And I put this here just to remind all of us about the ACE2 receptors, which usually the virus from the spike S1 and S2 gets bind to it. And this is can happen in the respiratory mucosa and other part of the body. Why I put it that's here? Because it is so important for us to remember that smokers usually will have increase of these receptors, and that will put them at very high risk. Even I couldn't find it that this is in all publication as a risk factor for bad outcome. They will mention the COPD and chronic lung disease, but smoking per se by itself, it will increase the rate of infection and rate of complication. And we know about the cases, actually it's getting higher worldwide, people getting infected. But the good news that the mortality you can see in the cartoon on the right is decreasing. And we know that there is some people who are at high risk, people in prison, nursing home, who work in meat packing plants because they breathe fast because of the cold weather. People are working in ships and the cruise, and even in the Marines. We know now that there is a special attention to the children since we decided to open the schools at the middle of this month. And there is an increased cases of already patients getting hospitalized because of the COVID-19. And you can see recently that the hospitalization has increased by 40%, and this is before opening the school, and that can cause a lot of consequences, especially a lot of hospitals, they do not have pediatric ICU if needed. And we know that this is very important. This is just published recently. Actually, this morning I was looking to the CDC after I prepared my talk. And the COVID is not only affecting patients who get sick, but people who are not sick. Like in military, people are counting the people who get dying during the invasion of Iraq, but there is the mental health status happen after that, where people, all these vets committing suicide. And I used to see it when I was working at the VA. A lot of people having with post-traumatic stress syndrome because I'm sleep specialist and they cannot sleep. And the same thing's happening now because people are losing their job and their income. And you can see in the United States, anxiety and depression symptoms increasing by 31%, increased substance use by 13%, like post-traumatic stress syndrome, 26%, and 11% are considering suicide, which it is significant. Now, we know about this in the past, that people in India are getting less disease and less mortality because they received BCG. And I thought when they were talking in India at that time that this is because of genetic factor, but even can occur in Caucasian. And you can see in slide C that even in the Caucasian, and when they received the BCG vaccine, comparing with people who did not receive, the mortality and the infection is much less in this patient. And we know also that there is some discrimination happening in the treatment of patients. This is all from the United States of America, that the minorities are getting less attention comparing with the others, and that has caused them to have more disease. I am very pleased here that in this country we treated all the same, even we have 80 nationalities, and we have a lot of people who are not rich. We all treated them the same. And you can see here that the Black and Hispanic having more disease and more hospitalization and more to die because of the COVID comparing with others. And that's in multiple states in the United States of America. Now, people will tell me that's because they do have comorbidity. That is true, but also because of financial issue. We know that African American has more obesity, has more diabetes, more chronic renal disease, and more sickle cell disease and hypertension. All these are risk factors and put them at high risk, but you can see that the social economic status is a problem. Also, the access to care and unemployment, and also socially when they cannot have social distancing, and that will put them in high risk. And what like in all this slide, that if the most important factor with all this is educating the population, and that is, I believe, the best weapon we have to stop this type of discrimination at the COVID time. And if you lived the MERS and SARS as I did, we lived SARS in America, we did not have mortality 9% at that time. And most of the cases were actually on Toronto. MERS here, it was more scary than the COVID, the mortality 34%. I have one of my respiratory therapists at that time gets the disease by taking care of patient, and he died because we could not save his life with severe neutropenia, white cells count of 0. And you can see the SARS is much, much less mortality. And I believe that's reflected why we did not deal with this disease from the beginning as a pandemic, because when we look, as all the politicians looked at the mortality and found it very less comparing with the other disease. And you have seen this slide before. But this is very important to me because we'll talk about a lot of things we have and we have not done to our patients with COVID. If you will see in stage 1, when the patients start to have the symptoms, I believe this is the window where you can use the antiviral. The antiviral, while at the end, where there is the cytokine storm, the host inflammatory response, when we give this antiviral, it may not work. And that was the problem. We, at the beginning, we stopped giving patients antiviral until they are very sick, and that's why it did not work. And for the time, I will go through this fast. We know, all of you know about the symptoms, mild symptoms and severe symptoms of COVID. But what it is alarming here, this is I am not cardiologist, but these are some cases we started to see in children, Kawasaki-like syndrome. And first gets published by a British group, and they saw that this will cause mortality, high mortality in children. It causes skin rash and multiple organ damage, including respiratory and cardiac. And you can see on the echo here that these children will have dilatation in the coronary artery. You don't see it usually, coronary artery on the echo, but it is dilated because of aneurysm.
Yes, and 1 minute. 1 minute.
Okay, and this is the same. We saw it in America. There was about 186 cases, and you can see it's affecting boys more than girls, and it's affecting the minority more. And I heard a lot of things about hypercoagulation. It's just because of increased hyperviscosity. These patients have thrombosis. They can have PE. My problem as a pulmonologist, that's we don't know how many people is going to have a chronic thromboembolic pulmonary disease later on. And that's why if any of these patients has any exertional shortness of breath, we need to look at that later on, because they may develop that, but we don't know what is the ratio. And we know this study came also recently, just last week, done in New York. About 14% of the health worker, when they screened about 40,000, has antibodies. Even they have not been diagnosed, quite a few of them, with the disease, and that's mean that they carry the antibodies. And this is very important now when we are talking about the vaccination, and we still know if this antibody will protect. And this hydroxychloroquine, the FDA removed it after 2 studies did not show, one in the Lancet and one in the British Medical Journal and one in the New England. And this is another study just published recently about hydroxychloroquine to protect them from having the COVID failed. I have a patient, I was going to report the case from the beginning, was taking 400 milligram BID for his lupus, and he came with very bad case of of COVID-19, because it did not help him in preventing disease. And this is done on a large number of patients, and you can see the result. I will stop here if you want me. I can just give you here about the Decadron. This is a recovery study published in the New England, done in multiple centers in UK, which shows that giving Decadron to patients who have severe hypoxia, not for everybody, because it may be harmful if you did to the patient not having severe hypoxia. Severe hypoxia, they may improve survival, and you can save one life by treating 8 patients while they are on ventilator and severe hypoxia. And I believe this is the most important study we have right now. And thank you very much for having me. I have more, but we'll stop here.
Dr. Kowatli, you are amazing. All these speakers, I wish that we had more time for you all, and we will in a next generation for TS, which is coming soon. We will have a lot.
Well, I like to thank Dr. Baron for her speak today, because I believe we need to be a human when we are practicing medicine rather than just having the medical information.
Absolutely. Thank you. Thank you. Okay, our next speaker is Dr. Khalid Malik, a regional medical lead and CMO with Upjohn. And we want to thank Upjohn and Pfizer, as well as King's College Hospital, London, Dubai, for their support of this great endeavor today. Dr. Khalid, take it away.
So thank you very much. Really appreciate the opportunity. I love the presentations before. We had so many eminent speakers. I would like to just thank the organizers for giving Pfizer Upjohn the opportunity to support and sponsor this project. I feel that being part of this very eminent conference is really an honor for us. Can everybody, can you hear me properly?
Go ahead.
Okay, thank you very much. So today I'm going to talk to you about a little bit out of the way. I'm not just going to talk to you about cardiac health, but I want to talk to you about the NCDs, which are the non-communicable diseases, right? The non-communicable diseases are key chronic diseases which the WHO are looking at in order to increase the mortality and morbidity. Upjohn is a part of Pfizer. It's a division of Pfizer, and it's that division of Pfizer that concentrates on non-communicable diseases. Our purpose is to create breakthroughs that change patients' lives. Our mission is to relieve the burden of NCDs with trusted quality solutions, and we emphasize on solutions. It's not just the pill. We're looking at solutions for every patient everywhere. And our ambition is to reach 225 million new patients by the year 2025. If you look at the NCDs, WHO, chronic illnesses, most of them come under the NCDs, but the key 5 NCDs are cardiovascular disease, chronic respiratory disease, cancer, diabetes, mental health, and neurological conditions. So today we are talking about cardiovascular. It is one of the key NCDs, and there's so many risk factors associated with this. And the WHO have coined this term as 5 by 5. So main risk factors: unhealthy diet, tobacco use, harmful use of alcohol, physical inactivity, and air pollution. So these are the key NCDs, and today we're talking about cardiovascular in this particular forum. But I think it's important for the audience to realize that there's a disproportionate NCD burden in the emerging markets, and we belong to the emerging markets right now. And if you see that there's 71% of all global deaths are happening within the emerging markets. That's about 41 million global deaths, right? And 85% of these, 41 million global deaths, 85% of these are happening in the emerging markets, right? And 1/3 of these are premature deaths. So these are those deaths that we can actually do something about. We can prevent them. And because we're not acting properly, we're spending roughly $7 trillion in trying to treat these. If we act, proactively, we will be able to spend only 170 billion. So it's a big cost issue over here as well. The main focus today is on mental health for me, right? Because I know there'll be so many of us talking about cardiovascular health today, but we have to consider mental health, because during the pandemic era, there are major implications for cardiovascular health and other patients, cardiovascular disease and other patients, because mental health is really being impacted in this pandemic era. There are direct health complications, and also there is a disruption of delivery of standard of care right now, because what we see is people are not getting to hospitals. If they're going to hospitals, COVID is getting the preference at the moment. So many people are being left without proper treatment, proper follow-up in this era, and that's also leading to a lot of mental anguish. What we see that pandemics increase the poor mental well-being, and there are several factors that contribute to that. Vulnerability and predisposition of mental health, that's one of them. Then people are working from home now. I mean, all of us, like for example ourselves, myself as well, we've been working from home for the last 5 months. There's no interaction, human-to-human interaction as such. That also adds to the stress. And then because of COVID, we've seen that there's been a big impact on unemployment. That leads to poverty. Poverty again leads to mental health issues. They cannot buy food. They cannot buy, proper diet. They have a poor diet now, especially in the underdeveloped countries. Most of the countries which I'm looking after as a lead of Africa, Middle East, I'm seeing this happening on a regular basis. There's also issues that we're seeing with domestic violence, which is leading to mental health problems as well. I mean, the previous speaker spoke about, the impact on mental health, and the suicide rates are increasing also. Social isolation, reduced access to healthcare. So all of these factors contribute towards a key issue, which is mental health issues. We need to, and as cardiovascular physicians, we also need to consider the impact that this COVID is having, not only in cardiac health, but also on the mental health. These, if you look at these challenges, they come among there's a fear amongst the community. So whenever there's an infectious disease, the communities always start getting scared, and that leads more to mental anguish. Economical aspects I just spoke about, environmental aspects, with regards to the lockdowns, etc. The outcomes of certain diseases because of non-access to medical health is also a big issue. All of these are leading to mental health, increase in mental health issues across the world. Social distancing, again, isolation, loneliness, all of these key factors that we need to consider. And then, people are fearsome of this illness and the recovery from this illness. So all of this has got a negative impact on our mental health. I, for one, I'm a very big proponent that whenever we see a patient, we should also try to analyze the mental health and mental well-being of the patient. And if we can do that properly, we should be able to, then channel them to the right person, because a person can have a fantastic heart, right? But if they're not well up here in the mind, then they're not going to be well at all. So we need to look at that as well. I won't go into too much detail, but interventions in mental health can start from the very beginning. We need to keep mental health in our minds. So we need to start well, we need to develop well, we need to live well, we need to work well, and at the end we need to age well as well, right? So these factors, will help us, better our mental health. One of my great friends and okay, thank you. One of my great friends and who is the head of the the president-elect of the World Psychiatry Association, Professor Abdal Javed, said that there is no health without mental health. So we need to concentrate on mental health. Like all of you guys, you're concentrating on treating patients. Upjohn, we're concentrating on the NCD treatment. Also, we're doing beyond the pill, solutions. And one of the solutions is Health Matters with Dr. Adam. I explained this last time when I saw you guys. We have a fantastic, digital platform which contains infotainment videos. If anybody has had the privilege to travel Emirates Airlines, you will see that this is now visible on the Emirates Airlines. You can see down here, the ICE magazine, we launched it over here. We have multiple episodes on this, and we have more than 300,000 views right now. We have now created Health Matter with Dr. Adam video on the COVID infection, and anybody who wants to use it can reach out to us, and we can help them, have access to this. If you want to see these videos more, you can go to the Get Healthy, Stay Healthy website, and this will give you, a preview of the videos that can be seen. These videos can be used anywhere else if you want to. If you want to contact me, this is my number, khalid.malik@pfizer.com. And I want to thank all of you for this amazing conference. And thanks, Annie, for your timekeeping. It's amazing. Really appreciate it. Thank you very much. Thank you, Umar. Thank you. Bye-bye.
Thank you, Dr. Khalid. That was a great presentation. Thank you so much for keeping on time.
Absolutely. All right. Thank you. Yes, we've watched that Health Matters on the Emirates Airlines, and it's really tremendous education for people. Now, we want to bring our next speaker, Dr. Al-Zubadi, who hails from Abu Dhabi there as consultant interventional cardiologist, going to speak about ST elevation myocardial infarction in COVID-19.
Dr. Al-Zubadi, he's the current president of Emirate Cardiac Society.
Wonderful.
He's an excellent indicator and excellent cardiologist.
Thank you. Welcome.
Sorry, I'm just trying to get my camera set. So thanks, Dr. Arman. Thanks to the organizer for the invitation to this very informative meeting. Yeah, can you hear me, please?
Yes, absolutely.
Yes. So I got a very brief talk here, and I'm just going to share with you a case of mine that we had, especially during the epidemic. So, we are relatively a busy centers. We do about 30 STEMIs a month between two sites. And one of the things we noticed is a decline in the number of cases, especially in the peak months, April and May. I'm going to show you those numbers. And also the mix of the patients, especially the STEMI and the COVID positive patients, the pattern of the disease and the presentation of those patients were a bit different than what we are used to. So I'm going to share with you a case and then just share with you a few slides that looked at one of the centers that looked at their COVID experience. And this was published recently in the JAC. So this is a 46-year-old gentleman who's relatively healthy. And he presented to one of the community hospitals with epigastric pain, and his ECG clearly shows a massive anterior lateral ST elevation myocardial infarction. And so, this case was taken directly to the cath lab. Of course, we noticed delays in getting and preparing the cath lab team, getting the patient to the lab because of all the different protocols of safety, or to take safety of the staff. The chest X-ray of this patient shows, prominent interstitial markings, and sometimes just difficult to differentiate between, is this a pneumonia or is this a pulmonary edema among our acute MI patients. So as you would expect, this patient should have an LAD target, and you can see the right coronary artery is a large vessel, dominant and free of disease. The LAD, interestingly, got two culprit lesions, as you would see here, one in the LAD, and then the second one is in the is involving the diagonal. So both vessels were wired, and multiple attempts with the balloon angioplasty were not successful to restore the flow. Aspiration thrombectomy was used, and despite all of those interventions and maneuvers, it was not easy to get to restore the flow into the LAD. So there is a heavy thrombus burden, and that is probably embolizing and distally, and affecting the microvasculature of these patients. So a lot of attempts, but no luck to get it back. So the patient was taken to the CCU. He was given a tirofiban and heparin infusion, and then a repeat angiography and attempt again a PCI to the LAD, which someone may question the value of that, but this was also done again in a couple of days, or the next day, I think, and this was not was also not successful. So this patient ended having a severe LV dysfunction because of this massive thrombi affecting, multiple coronaries. So just to share with you, I mean, the couple of points here. This is the cases that we had over the months, and so on average we get about 30 cases. Interestingly, in April and May there was a good drop in the cases, and we don't know the reason. Probably patients. It's a mixed, I would say, factors. One of them is the patients are afraid to come to the hospital, so some of them just had a had myocardial infarctions at home, and probably we're going to see their the complications of those patients who survived those MIs, and what we got is probably the worst of the worst of the STEMIs. The other thing is the number of STEMIs with the COVID positive is not as high as seen in some other reported series. But we did have a good number, especially of COVID positive patients in May and also in June. This is a single center experience that was published recently, a couple of weeks back in JACC. And as you would see, the baseline characteristics of those patients, are just shows you the the number of patients who had a very high troponins was the COVID patients had a more troponin rise, of course, more inflammation, and D-dimer, and all the signs of hypercoagulability is there. Another factors, of course, is the findings is multivessel thrombosis. They noticed that in 7 of the patients, like our case, stent thrombosis was higher in these patients. And another interesting finding is the flow, or the thrombus grade and the modified thrombus grade post first device, the TIMI flow. So all of those factors are indicative of a high thrombus burden in the COVID patients, and that makes it a challenge as to how to manage the anticoagulation and antiplatelets in these patients. The procedural outcome, as you can see here, the mortality, the intensive care admissions, and the length of stay are worse in the and the COVID patients. So that's a, you know, that gives us a feel that these patients are a different cohort compared to the usual STEMI patients that we see. So the more complex clinical presentation and geographic findings are more complex, of course, high thrombus burden, and probably a worse clinical outcomes. So that's simple, straight, and of course,
so much,
a lot of unanswered questions, Dr. Umar, for us in terms of managing these patients that were still, you know, we still need to learn.
We're still learning what to do, what will be the best way to do it. It is very kind of difficult, challenging. I mean, you try to aspiration, did not work.
Yes.
So it's a really tough one. And you did really kind of a lot of very aggressive management. But as you said, we still need to learn what is the best way to deal with those patients. Is it thrombolytic therapy maybe and a better option at this time for COVID? I guess something need to be answered. Thank you so much for your presentation.
Thanks. Thank you for.
Thank you, Dr. Zavadi. We're going to move onward to Dr. Kenneth Liao, who hails from Baylor College of Medicine, Professor and Chief Division of Cardiothoracic Surgery.
Yes.
We'll be talking about new technologies in cardiothoracic surgery. Dr. Liao.
Okay, great. Thank you. Can you hear me? Let me try to bring up the screen. Can you see my screen?
Absolutely.
Okay, great. So thank you for the invitation. Thanks, Dr. Omar Halak and Dr. Krazer and the organizing committee for the invitation. And my talk is about technology in surgery, whether it can help, particularly in this COVID pandemic season, in treating the patient. As you can see that, hold on a second, sorry. Make it good. So, okay, better now? Okay, good.
Yeah.
As you can see, the right now in Houston, in Texas, where the pandemic center, epicenter of COVID infection, and as you can see, we're the third largest state in the U.S. and have the COVID disease. Over 500,000 people get infected, and so as you can see in our hospital, the ICU is full in the last few weeks. And then in this kind of, it certainly has a lot of burden on the hospital, as well as the stress on the physicians, healthcare providers, as well as patients. So the people would ask, is it safe to perform open heart surgery now? So the answer is yes, but you have to go through this complex algorithms to make sure that this is done properly. So these two algorithms you can see on the left side is for the outpatient algorithm, how to safely conduct the surgery. And then on the right side is the inpatient setting, how to conduct COVID surgery in the COVID situation. But as you can see, like any algorithm, if you see very complicated with all these lines and charts, then that tells we do not know. We don't have a good solution. That's why it looks very complex. But the ultimate is to simplify is that if patient has COVID infection, is symptomatic, we should delay the surgery as much as possible. If someone recently had the infection, we should wait for 20 days, perhaps if not, waiting for 10 days, a minimum, before we do the surgery. And as for surgeons, we should wear the appropriate PPE. The patient has active COVID infection, we should wear airborne protection gears to do the surgery. So now that you can see that it is easier to wear the protective wear to perform the basic procedure such as intubation or do some suction of sputum, but to wear the airborne gears to perform open heart surgery, cardiac surgery probably is very difficult. Number one, you cannot see that well. Number two, it is very uncomfortable. You cannot wear it for too long and without and hurting yourself. So the other question we have now, the earlier part of the algorithm address to how to protect healthcare providers, surgeons to have how to perform the surgery without getting infected. But we have never really answered the questions to the patient. Is it safe to have open heart surgeries now in the hospital? As Dr. Kowati earlier presented, that about 13% of the healthcare providers are infected. And they are most of them asymptomatic, as a recent New York survey suggests, or antibodies suggest. So in the case like this, and are they safe to be operated upon by the healthcare providers? About 13% of them are infected or has a positive antibody, has positive virus. And then we know CDC has suggested the way that to control the infection is through social distancing. That's the 6 feet distance. Wearing the mask, that also can bring it down to 50% of reduction. It's never 100%. So now let's look at particularly the masks. Different masks has different ways, but none of this mask, even including surgical masks, mask in the corn one, that would not really completely prevent the virus leaking out from the mask. As you can see from this particular picture, even for the airborne, for the N95 mask, even though you can protect healthcare providers very well, protecting the person who wears, but unfortunately it doesn't prevent the virus leaking from the person who is wearing the mask to the environment. So as you can see, if you wear the surgical mask, about 50% of the particles can leak out easily. If you wear N95, about 30% of virus can still leak out to the environment. So now just imagine that we have not even considered the orifice, the recipient orifice area. If the recipient has a wide open orifice to be exposed to the virus environment, then what's the situation? What's the risk of infection there? As you can see, imagine in open heart surgery, the patient's chest is wide open, and the surgeon wear the mask, and then we're staring at this big heart, and do the surgery standing there for hours. And then to do that, and what's the potential risk of the provider's assistance and the leaking through the mask to those patients' chest and to the heart, and then suck out in the bloodstream? Is direct virus drop into the blood system. Just imagine. So no, we do not know. So that's what it's rightful so for people are concerned about to ask a question. It is safe to have open heart surgery. So next, always in the past, now we need to find a solution. We need to find the answers. The cardiac surgeon is, and we always need to think about, is there a way to improve patient safety without compromising the surgeon's ability to perform the surgery? So now yes, there's a way. The way is now, like any time we have difficulties, as the pioneer cardiac surgeon, Dr. Lillehei, has taught us what mankind can dream of research and technology can achieve. In the earlier years, when he was cardiac surgeon and he was told the open heart surgery is a forbidden area, nobody should touch the heart. But however, he used the biological parents to use the heart-lung machine, biological heart-lung machine, to successfully perform a series of congenital heart defect repairs. Because of his pioneering surgery, and then the whole field of open heart surgery opens up. The same is for the space technology. As you can see, the recent SpaceX launch of space shuttle from the first generation of Apollo to most recent Dragon one. This is exactly the advancement of the technology can make a huge difference. It's much safer, easier, and everything looks good at the end. So now what's the new technology? Similar technologies like SpaceX in cardiac surgery. It is a robot. It is a robotic that we have Da Vinci robotic system. The concept is the surgeon is operating on the computer console to control the operating controller. The assistant insert the tools into the patient's body, and then the surgeon would operate upon the patient. As you can see, this specific setting I want to show you, this is the daily routine in our center, Baylor St. Luke's Medical Center. We use robotic surgery every day and then to perform this cardiac surgery. As you can see that the surgeon is away from the patient. And then there's a distance. The assistant is also has to keep a distance from the patient. And then the orifice of the patient's opening spot is very small. The chance of getting exposed is small. Plus, as you can see, the tube we inserted into the space is CO2 tube. We insufflate the CO2 carbon dioxide into the operative field. There's constantly CO2 coming out up from the cavity towards the surface. So there's no bacteria or virus can drop in. It's always coming outside. But this way, through a small surface and through the CO2 prevention, then this actually can, to a certain degree, protect patient from getting the virus exposure and the infection. So how this was done, the technology. So as you can see, this is the mitral valve repair. We typically this is the prolapse mitral valve. As you can see here, we grab it, identified it, and then we'll use a pair of scissors to. Oh no, a pair of scissors to cut. Yeah, a pair of scissors to cut out this ruptured and the core, the ruptured piece of the valve. And then after that, we stitch the valve, the normal valves around it together with the Gore-Tex sutures. It's all done through the robotic assist control and the instruments. And then after that, we completed the stitching first to bring this normal structure together, the valve. And then we place annular plastic ring on the we inserted annular suture to anchor the ring on the mitral annulus. Actually, the image visualization is through 3D, and the surgeon saw a 3D picture, and it's 10 times magnification. It's very clear, very precise. I would say the movement is very gentle on this, on the, hold on 1 second. Okay. So then we put the band in onto the valve annulus, and then we tie the nuts. Everything is automatic. As you can see, we don't use the hand tie anymore. Now we test the valve after repair. The valve looks great. So I would stop here, and I just want to show you, demonstrate to you, this is a new generation of technology. You can achieve, do the fine surgery, and but at the same time you can protect the patient in a way that you never thought about before. And I want to thank you for your attention, and thanks the opportunity to give the presentation.
Dr. Liao, that was amazing. And we always are in awe of our cardiovascular surgeon colleagues. What great things you can do. We thank you so much for that. We're sorry we're so limited in time.
Yep,
our next speaker will be Dr. Abdul Barrow from Mississippi, hailing from the South, just like me. I grew up in Georgia. So Dr. Barrow, take it away. You're going to talk about critical limb ischemia.
If I should second that? Yes, that's even know. Yeah. So that's really good.
All right. We will need Dr. Liao's slides down and Dr. Barrow's slides up, please.
Got my.
All right. That's good. Y'all are doing so good. I told Dr. Halleck in between all of these, I said, we need 4 hours of conference, not 2, because we have too many great speakers.
You absolutely need a little bit of break in between to absorb the delay, because we so many great talks and we kind of feel bad to cut it short. Yeah, hopefully
Sure.
Next time we'll do a better job. Yeah.
Of course. Dr. Barrow, very good.
Trying to get my presentation. 1 second, please.
Dr. Barrow?
Yes, I'm here. Can you hear me?
Okay, yeah, go ahead, please.
Trying to get my presentation. 1 second. Hold on 1 second. Check him out.
Share screen.
Yeah, it's sharing. Just everything was working fine except when I start my presentation.
If you
It's
want
probably
some
because
more
I told
time,
you to
yeah,
speak from the
no
heart.
problem. If you want some time, we can start with Dr. Samer if you want to. Do you want some time or you'll be okay?
Would you like just to go to the next one and to give you some time?
I think it's a good idea.
Okay. All right.
Go for Dr. Samer.
Dr. Samer, are you there? Dr.
I
Samer
am
Elham?
there, ready
All
and
right.
happy.
Well, we
Sorry for the
welcome you.
delay.
We welcome you to our stage. This has been truly a world stage, and you're going to be talking about telemedicine. The future
Yes.
is now.
So do you see me? Do you hear me? Can you see the slide?
Okay, we're waiting on your slides.
Can you see the slide?
No
we
slides.
don't see it.
Yes or no?
No.
No.
There you go.
Okay.
Now we see it. Yeah. By the way, Dr. Samer, one of the very highly educating doctors here in Emirates and worldwide. He has so many articles, almost on monthly basis. He have published an article in one of the major journal in USA worldwide. He is one
It says
of
it's
the,
sharing. Thank you. Can you see now?
In the quality.
Yes.
Can you see it? Yes?
Yes.
Okay. So my presentation is less than 10 minutes. Thank you, Dr. Amar, my friend and colleague, all the speakers. Thank you, Baylor. Thank you, surgeons. Very brief. So as you know, one of the major change management that happened with COVID-19 is this concept of telemedicine, telehealth, and medicine, artificial intelligence, moved speed of light. Major change, people adopted it, the Congress, Medicare, Medicaid in the States and here, etc. So I'll just give you a flavor and give you some ideas about this. So with that in mind, all of us know that, we had to go through this. So in Cleveland Clinic Abu Dhabi, where I'm currently working, we have barely had any cases where we saw patients virtually. This was almost 80, 90% for almost 4 months. And now it's going down. And that's something to be discussed in another meeting. I'm on the editorial board of Telemedicine and Blockchain Journal. Again, we've seen articles that were submitted showing 80, 90% increase in the States and Europe and our areas, but it's really dipping down. Telemedicine is a big deal. What's the difference between telemedicine and telehealth? So telemedicine is used of technologies to remotely diagnose, monitor, and really manage patients. Telehealth is like the forest, and telemedicine is the tree. Telehealth includes mHealth, artificial intelligence, what my dear colleagues from cardiac surgery discussed today, which is robotic medicine. So there were, before COVID-19, so many things going on, at least in the States and Europe: consumer demand, cost saving, value-based care, etc., pushing a little bit the pendulum towards the telemedicine, but really very, very slowly. When the COVID-19 came up, and we're talking perhaps, early March especially, things started moving remarkably faster. And this virus has truly transformed healthcare, but also showed areas of improvement and opportunities of improvement. The issue of face mask and PPE, which my dear colleague from cardiac surgery discussed, and other colleagues, is a big deal. This is a paper I've written on domino effect of medical error, and it talks about if you have a first victim, then second victim, at the end of the day, the whole community is being affected. And that holds so true when it comes to COVID-19. With that pandemic, this whole thing tested our healthcare system, and virtual telehealth became a reality, and we all know about this. Social distancing, that simple concept that people can barely accept it, even in our countries and the States, is becoming truly one of the key ways to address this, and hence moving telemedicine there. So I'm giving here an example of a patient that could or could not have COVID-19, but is sick. And basically, we're always open, right? You can have this even 24 hours a day. You can even do one in Australia and one in our areas, and we can do it with you, and we can have a 24-hour system. And this will prevent emergency rooms from being overcrowded, limit exposure, and that's the most important. And quite honestly, patients and the caregivers are quite annoyed with the face mask. I was seeing patients and busy on Thursday. I came to CCAD at around 6:30, and I left at 6:30 with the face mask, which is not easy. This is a quick article from Gulf News. COVID-19 pandemic increases UAE acceptance of telemedicine, nothing unusual. Very quickly, and to be on time, patients want safety, healing, be kind to me, but they want to be engaged. And this technology truly engages patients if done properly. What is telemedicine? I think increasing patient engagement is a key thing that we saw in the COVID-19 era, and I hope you have the same feeling. The numbers started increasing. This is up till 2012, barely an increase in the States. You should see the statistics from March till now. Telemedicine also can widen the scope of medical practice. One simple example, not to take too much time, is the kind of follow-up we can have with the patient, not by calling by phone, but something a lot more, and especially in cardiology with the mHealth and the watch and the phone, etc. I mean, time does not permit me to discuss this. Dr. Fakhri and Dr. Omar, remember, we were talking about a basic, usual clinical cardiology topic of systemic hypertension. I was asked to talk about it, and we've shown ample data from European Society of Cardiology and JACC that this probably is there, but we need a little bit more research on this. In summary, to be on time, quite a few benefits. Limitation is really the physical exam, and obviously the whole idea of video component. Like I had the patient in an area called Sila on Wednesday. I simply could not connect with the patient because the internet was poor. This is around 4 hours from our center. Remember, if you add to it innovation and talk about mHealth and talk about artificial intelligence and machine learning, you're talking about literally moving towards the patient owning their own health, having their records, sending us message, and transforming healthcare completely with COVID and without COVID. And I'm not going to take too much time on this. Summary, quality-wise challenges, providers' credentials. We don't have currently appropriate credentialing, including Texas, including Washington and Cleveland, where I came from. Continuity of care is an issue because many times patients are seen by one person, another person, and obviously the efficacy. The appropriate use and clinical triage is adequacy of virtual exam. I mean, I still like to use my stethoscope, but now there are many ways to do this, and the patient selection. Just quickly, this is a model from a society dear to our surgeons and to all of us, where they have a model, which I will not discuss, to really do this for the outpatient, and it's been tested, I mean, obviously for a few months, not more. The train has left the station. So Dr. Annie, are you going to be with us in the train or not? And all of us. So, and we are, according to Time Magazine, we are the person of the year. So what I did over the past 2 years is I got excited about this topic before COVID-19, as Dr. Omar said. We looked at telemedicine. We currently publish a key journal, article on blockchain in COVID-19 with our colleagues from Khalifa University, other things. We also looked at application of artificial medicine, etc. But really, telemedicine is not the future, it is the present. And it is really upon us as clinicians, my dear cardiac surgeon, my vascular, my dear colleague from pulmonary, and my friend, and all of us, we really need to sit down and do 3 things, and I'll stop here. And hopefully Dr. Annie is still smiling. Number 1, and most importantly, we need to regulate this and add a flavor of ethics. Number 2, we need to work with our insurance company and make sure that this is appropriately covered. But the most important thing is the 3rd one, appropriate use, efficiency of use, and efficacy, so that this truly adds value and we have what we call value in healthcare. Thank you so much.
Dr. Summer, thank you very much. That was excellent presentation. Even when Dr. Barron was speaking, she mentioned that we had done seminar with even the Baylor students, the pre-medical students, teaching them that telemedicine is up and coming, and it's here. So we have to all learn about it and use it. Thank you so much. Our last speaker.
Summer, that was a great seminar.
Thank you.
Dr. Barron, are you ready with your slides? We want to give you that opportunity to speak. This will be the last talk.
So we click share screen, right?
Click share screen, that's correct.
We'll see if it works this time.
All right. Otherwise, you're going to speak from your heart. That's what I told you.
Very good. Can you see the presentation now?
Yes, very good. Go ahead.
Yeah, it's unfortunately my presentation is nothing to do with COVID-19, because what I do mostly peripheral vascular disease. We've seen many patients with necrotic fingers and toes with COVID-19, but unfortunately nothing you could do with percutaneously. So this is mostly medical treatment. So I thought change the subject a little bit and show you some good cases, because most of what I heard about COVID-19 is like kind of unfortunately depressing cases. The result most of the time is not the best. You know, we have diabetic patient, it's spreading very fast, as well as renal disease with dialysis. Patient getting more and more around the world from the bad habit we eat, from no exercise program, all of that. And we've seen a lot of cases with the arm necrosis and fingers like getting almost dead. I thought I'm going to share some cases with you. Those cases could be helped definitely, but unfortunately the treatment for those cases has been very, very limited. Surgically, barely you can do anything. So most of what you can do is percutaneously. This is a typical normal perfusion to the arm. You see the hand, it gets through the radial and ulnar arteries with the palmar arch supplying the digital vessels. Now, this is one of the cases I'm going to show you some. This gentleman presented with necrotic changes to the tip of his fingers, very painful. He went, saw a surgeon for 2 weeks, put him on heparin, nothing helped, so he came to us. And as you see on the angiogram, he has short segment of occluded radial artery, which is the only vessel to the hand. So we took him to cath lab, crossed the lesion, atherectomy with atherectomy device, followed by balloon angioplasty. And this is when we finished from him. And geographically, the vessel is wide open. He got significant supply to the hand. And can you hear me? And this is when he came with for follow-up 4 to 6 weeks later, completely healed. A second patient, you can see the tip of his index finger, the same thing. Most of those patients, by the way, on dialysis have renal failure or diabetic patients. This guy presented to us like this. We took him to cath lab. He has short segment above the wrist of significant calcified lesion in his distal radial artery. The same atherectomy with atherectomy device followed by balloon angioplasty, restored the flow. Then follow up, the surgeon took the necrotic tip of his index and completely healed. Another patient, you can see the tip of his index finger and middle finger. When we took him to cath lab, and he has one vessel run off to the hand through the radial artery with multiple severe stenotic lesions, heavily calcified, as you can tell. The lesion crossed, atherectomy was performed, pictures follow up after angioplasty, and that's what he got to his hand. Some of them, they don't come for follow-up because they feel good. This is one of the dramatic cases we've done. As you can tell, this is the left hand, and on the right screen is the right hand. This gentleman starts losing finger after finger, and you can see he has fresh surgery on his left thumb. The surgeon kept knocking off part of his hand every time he sees him because not much options surgically. So we brought him to cath lab and we worked on both hands. And as you can see, this is a radial artery, this is an ulnar artery, and the radial artery is almost completely occluded. After we work on both arms, you can see atherectomy, balloon angioplasty, that the result, we almost restored the flow in all 3 major vessels to the hand. And that's what he got on the right side of the screen, the perfusion to the hand. And I'm just gonna show you how bad is the pain after we did him. If I can play it, okay. It's not playing. Okay, that's fine. That's fine. That's fine. That's when I saw him for follow-up. As you can see, all the wounds almost completely healed. What's sad about this patient, you can see his wheelchair, he has no legs also. So he lost his legs already and lost much of his hands. I'm gonna bypass this case and this one for the sake of time. This is an interesting case, as you can tell. The tip of the middle finger, necrotic, very painful. Took this patient to cath lab. You can see in the radial artery, very distally, almost above the wrist, very high, very severe calcified lesion, blocking the flow completely to the hand. There is one here and another lesion here. This is, hopefully I can play the film. How can you play it? Let me see if I can play it. How can I do that?
2 minutes, please.
Trying to see if I can play this video. Okay. Nope. Let's go back. That's fine.
Sorry.
Okay. Having problem playing the videos on Zoom. I'm gonna go back to this picture. anyway, this is the atherectomy, and that's when did balloon angioplasty way distal to the radial artery. This is another patient. You can see the thumb, and this is very interesting. I tried to go from both the groins. She has occluded distal aorta. This is a distal aorta. So I went from the brachial artery in retrograde fashion and took angiogram. This is the radial, is occluded, and this is the ulnar where the lesion. She has one vessel runoff to the hand, which is the ulnar artery with lesion here. The only way I can reach it either from the left arm, which I tried, but it's very tortuous to go around to the right arm. So I decided to go retrograde from the ulnar artery, and I went bareless without any sheath. So you can see my needle with my wire. This is my balloon angioplasty. And that's when we finished from the case. We restored the flow in the ulnar artery. This is another case. You can see the tip of the thumb, necrotic. This patient had dialysis shunt, had many stents put in her venous side. You can see the brachial artery has short segment of severe calcified disease and barely any blood flow to the distal to the elbow. That's what she got to her hand, barely any blood. So we did atherectomy, balloon angioplasty.
1 minute.
And that's what we got the flow restored to her finger. And this is like 3 months follow-up, completely healed. I'm gonna go through this quickly. I'm just gonna show the last two cases. We did them last week. This is one of them. As you can tell, the surgeon took the finger off and put some graft. It did not heal, so he asked me if I can do anything. You can see here the radial artery completely blocked off in the mid of its portion. Ulnar artery is gone. So we went through the radial artery percutaneously, balloon angioplasty, and that's what we restored the flow to her hand. And this is the last case. You can see the hand. And this patient was brought to cath lab. If you look to close up here, you can see heavily calcified lesion in the distal radial and in the proximal palmar arch almost. And this is the major supply to the hand. So we took him to cath lab. We did balloon angioplasty, atherectomy to both lesions, and that's what we got the result. No follow-up yet because we just did him last week. Thank you.
Thank you so much, Dr. Barrow. I want to tell you that this brings us back home to how amazing, what an opportunity we have to save life and limb, even in this COVID or without COVID, how great of a specialty interventional cardiovascular training is, as well as cardiovascular surgery. So we thank you all for all of your great contributions. I want to hand it over to Dr. Halak and Dr. Krazier. Thank you all for giving me this opportunity to represent 4TS really to the world. Thank you so much. Take it away, Dr. Halak and Dr. Krazier.
Thank you so much, Annie, for your great work of moderating and keeping everybody on track. I think it was a great job, and thank you again for not able to forgive us not able to do your presentation tonight. Hopefully, we'll do it soon.
Next time.
Is a great cardiologist, great person. She is coming. She's planning to come and extend her office here to Dubai and to do the preventive cardiology at the King's. Thank you again, Dr. Annie, and now Dr. Krazier.
Thank you, Omar. I think this was a very informative, educational webinar. I learned quite a bit. There were a lot of information that was provided to us about COVID. I think it's one of the most comprehensive webinars, and I participate a lot of them on COVID-19. We have all learned a lot, and we hope we'll be able to continue with similar webinars and also with 4T's meeting in February in Dubai, whether it's going to be virtual or a combination of virtual and live. It's yet to be determined depending on the COVID situation and the vaccine issues that we are dealing with at the present time. But let's be optimistic and let's hope that we can address and resolve this problem before it happens, because big things are supposed to happen in Dubai. Next year is going to be a big year for Dubai and United Arab Emirates. So Omar, you might want to mention a few things about it. Why is Dubai going to be important for next year?
We'll keep it a surprise. So we'd like to everybody come to Dubai and see it, witness it themselves.
Right.
Thank you very much. It was great. And hopefully we'll meet all of you in mid-February here in Dubai. We will keep in touch, and then we'll. It's going to be virtual or hybrid or completely physical. I hope that we'll able to make it as normal in Dubai, and we enjoy the exciting city here in Dubai. Thank you again, and sorry for being late tonight. It was very tight schedule, very rich one, but I think I learned a lot myself, and it was great. Thank you very much for all the speakers and for all our audience who stay with us to the end and for even beyond. Thank you so much, and good night in Dubai time, and good morning, midday in Houston and other part of US. Thank you so much.
Bye.
Love you.
Great job, Annie. Thank you.
Thank you.
Bye.
Bye.
Come on.